Good morning, one and all. Today I am going to take disseminated intravascular coagulation. What is disseminated intravascular coagulation is? It is a systemic activation of coagulations. So because of the systemic activation of the coagulation factors, there is a formation of thrombi throughout the microcirculations. It may be due to the complication of wide variety of disorders, right? So what is systemic intravascular coagulation? It is a systemic activation of coagulation factors which leads to the formation of thrombi throughout the microcirculations. It occurs in wide varieties of disorders. Let us see the complications which leads to the disseminated intravascular coagulation. First, we see the obstetric cause. Obstetric causes are abruptio placenta, retained dead fetus, septic abortion, amniotic fluid embolism, toxemias. Infective causes are either infection with the gram-positive and negative bacteria, meningococcemia, Rocky Mountain spotted fever, histoplasmosis, aspergillosis, and malaria. Malignant causes are carcinoma of pancreas, prostate, lung, stomach, acute promyelocytic leukemias, even a trauma, burns, extensive surgeries, acute intravascular hemolysis, snake bite, giant hemangioma, shock, heat stroke, vasculitis, aortic aneurysm, and liver diseases can also cause DIC. I just repeat the etiology of DICs. Obstetric causes are abruptio placenta, retained dead fetus, septic abortion, amniotic fluid embolism, toxemias. Infective causes are both gram-negative and positive bacterial sepsis, meningococcemia, Rocky Mountain spotted fever, histoplasmosis, aspergillosis, malarias. Malignant causes are carcinoma of pancreas, prostate, lung, stomach, acute promyelocytic leukemias, burns, trauma, extensive surgeries, acute intravascular hemolysis, snake bite, giant cell hemangiomas, shock, heat stroke, vasculitis, aortic aneurysm, and liver disease. These are the some of the etiology for disseminated intravascular coagulation. Next, we will see what are the pathogenesis of disseminated intravascular coagulations. First is there is any insult to our body, it will releases it will activate the coagulation factors. That is first point. There is the activation of coagulation. And second, there is the process of thrombi formation, which is called as a thrombotic space. And third, it will all the coagulation factors will be consumed for the thrombi formation that comes under the consumption phase and followed by secondary fibrinolysis. So these are the various pathogenesis or steps involved in the disseminated intravascular coagulation. First is there is the activation of the coagulation followed by a thrombotic phase, followed by a consumption phase and secondary fibrinolysis. Let us see in detail what is the activation of coagulation. As I told previously, there are various etiological factors. These etiological factors will initiate the coagulation pathways. mainly by the release of the tissue factors, that is a factor 7, right? This will get activated and followed by a thrombotic phase. Thrombotic phases here, various etiological factors can cause even endothelial damage, and this endothelial damage is caused by the various thrombogenic stimuli. Once this endothelial damage has occurred, as a result, there is it may activate platelet adhesion and aggregations. Because of the adhesions and aggregations, this may lead to the deposition of small thrombi and emboli throughout the microcirculations. Right? There is a deposition of small thrombi and emboli throughout the microcirculations. Right? First, we have seen there is an activation of the coagulation pathway, and next we have seen the thrombotic phase. In the thrombotic phase, once there is the endothelial damage, exposure of the subendothelial collagen and will lead to the stimulation of platelet adhesion and aggregations, followed by deposition of small thrombi and emboli throughout the microcirculations. Once there is a deposition of the thrombi, then it comes to the consumption phase. In the consumption phase, it is followed by the thrombotic phase. Here, there is a consumption of the coagulation factors and the platelets, right? So, after the thrombotic phase, the thrombi formed, which is followed by consumption of the coagulation factors and the platelet, which leads to the consumption phase, right? And next is followed by secondary fibrinolysis. Secondary fibrinolysis, actually it is a protective mechanism where a fibrinolytic system is secondarily getting activated at the site of intravascular coagulation. Wherever the intravascular coagulation has occurred, as a protective mechanisms, our body tend to break the clot which is formed with the help of fibrinolytic systems, right? The secondary fibrinolysis, because of this, the clots will get break down, and because of this, you can able to see the fibrin degraded products will be seen in the circulation. That is what it is written here. Secondary fibrinolysis causes breakdown of fibrin, resulting in formation of fibrin degraded product in the circulations. Right? First phase is the activation of the coagulation pathway, and second is it is a thrombotic phase, and third we have seen is the consumption phase, and followed by secondary fibrinolysis. All the clots which are formed is break and leads to the formation of fibrin degraded products in the circulation. So this picture will clearly tells about the pathogenesis of the DAC. Now, if you are seeing here the first arrow, you can able to see the activation of the coagulations. Then this activation of the coagulations either can be intrinsic pathway or it can activate the extrinsic pathways. Sometimes there may be endothelial damage. Because of this endothelial damage, to heal that, and the subendothelial collagen is exposed, which is more thrombogenic, will causes platelet adhesion and aggregations. And once the adhesion and aggregation is formed, there is a formation of the thrombi, right? This is the consumption, this is the activation of the coagulation pathway. Then there is a formation of the thrombi, which is called as a thrombotic phase, and followed by it takes the it goes to the consumption phase. In the consumption phase, it takes all the coagulation factors, platelets, everything whichever there it's there in the circulation, which is taken by the clot, and it will increase the size of the clot. And as a protective mechanism, secondary fibrinolysis will occurs, and it will try to break all the clots. So there is an increase in the fibrin degraded product in the blood. So this is the pathogenesis of disseminated intravascular coagulation. Let us see what are the morphological changes occurs in our body because of the disseminated intravascular coagulation. First is, everywhere throughout the microcirculation, you can come across microthrombi. So microthrombi will be seen in arterioles and also in the capillaries. This microthrombi will be seen in almost all organs like kidney, adrenal, brain. These are some of the vital organs. So almost all organ, no organ is spared in the microthrombi DAC. So everywhere you can able to see the microthrombi in the DACs, mainly in the arterioles and capillaries. In the next slide, we will see what is happening in the kidney. So kidney, as all we know, glomerulus nephron is the functional unit of the kidney, which is composed of tubules and the glomeruli. In the glomeruli, when you are seeing under the histopathological HNE stained sections, you can able to see inside the glomeruli, fine small fibrin thrombi will be there. Right, inside the loops of the capillaries of glomeruli, you can able to make out small fibrin thrombi, and there will be sometimes you can able to make out the swelling of the endothelial cells. You can also see some features of the glomerulitis, right? Because of the infarct, you can also come across because of the inclusions, there may be small infarct everywhere. If the micro occlusions is very severe, then it may lead to the ischemia, and it will destroy the entire cortex and finally end up with the bilateral renal cortical necrosis. So one among the feature of the DAC is there is a infarcts will be seen in the renal cortex. If it is severe, then you can go, the patient can go for bilateral cortical necrosis. If the same glomeruli, if it is there in the adrenal, then the patient can go for the Waterhouse-Friderichsen syndromes. Let us see what is happening in the brain. Again, the same micro infarct will be occluding the brain, and it may causes ischemic injuries in the brain. And this micro infarct will be surrounded by the hemorrhage, both by the microscopic and the grossly we can able to see the hemorrhages around the micro infarct. Similar changes are seen in the anterior pituitary, heart, everywhere you can able to see the similar changes. And a special entity called the Sheehan syndrome. This is the DAC that occurs in the postpartum women, which leads to the pituitary necrosis that is called as a Sheehan syndrome, right? So you should remember what is Sheehan syndrome. Sheehan syndrome, that is DAC that occurs in the postpartum women, will lead to the ischemic pituitary necrosis, can develop Sheehan syndrome. So far, we have seen the morphological changes that occurs in the DAC. First thing is kidney change. We have seen kidney in the glomeruli. We are seeing fine small thrombi will be there, and this thrombi can lead to the ischemia and followed by a renal cortical necrosis. If it involves in the adrenal, it may goes for the Waterhouse-Friderichsen syndromes. And if it is involved in the brain, then it will go for the ischemic necrosis of the brain. Grossly, you can see grossly and microscopically, this ischemic area will be surrounded by the hemorrhage, will lead to the bizarre neurological signs, and the similar changes also seen in the heart, anterior pituitary, and in the postpartum women with DAC can lead to the pituitary necrosis, end up with the Sheehan syndromes. Let us see the clinical features. Clinical features of the DAC, it may be based on the severity. It may be minimal clinical features. Sometimes if fast, like everywhere the circulation has microthrombi, then the patient can go for the shock, acute renal failure, dyspnea, cyanosis, convulsions, and coma. So these are the some of the clinical features. So the patient can go for shock, acute renal failure, dyspnea, cyanosis, convulsions, and coma. These are the some of the clinical features. And this patient can go for the bleeding tendencies. You can see a diffuse petechia and ecchymosis everywhere, starting from the skin, and the serous lining of body cavities, epicardium, endocardium, and lung. And this patient also, there may be hemorrhages in the mucosal lining tissues like urinary tract will also shows bleeding tendencies like hematuria also seen. So the clinical features of the DACs are the patient can have present with the minimal features, or the if it is extensive, the patient can go for the shock, acute renal failure, dyspnea, cyanosis, convulsions, coma, and the patient can also have bleeding tendencies. And the bleeding tendencies, there is the diffuse petechia and ecchymosis will be seen on the skin and the serosal lining body cavities, epicardium, endocardium, lung, mucosal lining of the urinary tract. Right, so far we have seen the clinical features. Now we are moving on to the before going into the laboratory investigations, I just wanted to include something about the coagulation cascade pathways. See, in the coagulation cascade pathway, usually we will be having the extrinsic pathway and intrinsic pathways. In the extrinsic pathways is usually activated by the tissue factors, and factor 7 is getting activated, and after factor 7 is getting activated, it will activate the factor 10, right? That is the extrinsic pathways. And intrinsic pathways, factor 12 followed by it will activate factor 11, factor 9, factor 8, then it will activate the factor 10. This all are intrinsic pathways. So the time used for detect any abnormalities in the extrinsic pathway, it is the prothrombin time, and intrinsic pathways are detected by the activated partial thromboplastin time, right? And once factor 10 is getting activated, then it will, with the help of factor 5 calcium, prothrombin will be converted into thrombins, and this time is thrombin time. And next is this fibrin, this formed thrombin will be activating fibrinogen, will lead to the finally clot formations, fibrin clot. So this is the coagulation cascade pathway. So to find out any abnormality in the extrinsic pathway and intrinsic pathway, we have to follow this timing. Extrinsic pathway by the prothrombin time, intrinsic pathways by detect any abnormalities are detected by activated partial thromboplastin times, and the common pathway you can go for the thrombin time. Right, with this basic idea about the coagulation pathway, we'll move on to the laboratory diagnosis. How we are going to see the laboratory, how we are going to interpret the DAC. First is because of clot formations, platelet adhesion and aggregations, platelet count in the circulation will be less. So platelet count will be low. And next is that is prothrombin time, thrombin time, activated partial thromboplastin time. All these times, both extrinsic, intrinsic, and common pathways, the time duration will be prolonged, right? And the fibrinogen level will be reduced due to the consumption in the microvascular coagulations. After this, fibrin degraded products will be raised once because of the secondary fibrinolysis. So these are the laboratory investigations. So laboratory investigations are platelet count will be reduced, prothrombin time, thrombin time, activated partial thromboplastin time will get prolonged, plasma fibrinogen level will be reduced, and fibrin degraded product will be raised. So next we'll go for the peripheral smears. Peripheral smears, you can able to see the cystocytes and fragmented red cells will be seen, right? What is cystocytes is the RBCs. When it passes through the fibrin thrombi, it goes for the fragmentation, that is called as the cystocytes, and you can able to see the polychromatophils in the peripheral smears, right? So this is the peripheral smear. You can able to see the broken RBCs are there. This is all called as a cystocyte, the various size, and you can see the blue color thing, that is the polychromatophils. So these are the some of the investigations with the basic investigation itself, peripheral smears and platelet count, coagulation studies. We can be able to diagnose the disseminated intravascular coagulations, right? And this is the recap of whatever I've told. So as I told previously, it is the various etiological factors are responsible for the DACs. Examples are obstetric cause, malignant neoplasms, trauma, burns. All this causes release of the tissue thromboplastin, and this will activate the extrinsic pathways. Even the infective causes like gram positive, negative bacteria, Rocky Mountain spotted fevers, meningococcemias, all can causes release of the tissue thromboplastin, will activate the extrinsic coagulation pathways. And the etiological factors which causes endothelial injuries are aortic aneurysm, severe hemolysis, and hemangiomas, all causes endothelial injuries. Following the endothelial injuries, there may be platelet adhesions and aggregations. It will activate the intrinsic pathways. So both intrinsic and extrinsic pathways will get activated, and this will lead to the this is the first stage. So coagulation factors is getting activated. Next is thrombotic phase. Thrombotic phase is there is a formation of the intravascular coagulations. Once the coagulation is formed in the microcirculations, then it tries to consume all the coagulation factors and platelets. That is the consumption phase, and followed by there may be a secondary fibrinolysis. In the secondary fibrinolysis, as a protective mechanism, the fibrins are breaked and leads to the fibrin degraded products, right? And sometimes it may leads to the occlusion of the microthrombi. A final end product of this DAC is the patient can complain of bleeding, ischemic tissue injuries, even microangiopathic hemolytic anemias will be seen in the patient. This can be diagnosed by the basic simple investigations like platelet count, coagulation studies like thrombotic time, activated partial thromboplastin time, prothrombin time will be prolonged, fibrin degraded product will be increased, and plasma fibrinogen level will be decreased. So with this basic investigations, even with the peripheral smears, you can able to see the cystocytes and polychromatophils, reticulocyte count will be increases. So these are the some of the features, laboratory findings you have to remember. Hope so you have understood well about the DACs. If DAC is asked, you should tell about what is DACs and what are the etiological factors and what are the phases which are involved. That is activation of the coagulation factors. Next is thrombotic phase, consumption phase, secondary fibrinolysis, and what are the morphological changes that occurs in the kidneys, brain, and various organs. Next, you should learn all those basic investigations which are done in the DACs. Hope so you understood very well. Thank you very much.